Thank you for joining us for the final talk of Day 1 of Advances in Proteomics and Metabolomics 2023. I'm George Hammond, Conference Producer at Technology Networks, and I'm here to introduce our final talk of the day, Identification and Analysis of Non-Invasive Biomarkers in Exhaled Breath. It's my pleasure to introduce Dr. Tina Chou, a distinguished biomarker scientist at Owlstone Medical, where she is responsible for supporting customers with study design, data interpretation, and report delivery. She holds a PhD in plant science from the University of Connecticut and has honed her skills through several years of postdoctoral work, specializing in omics data within the broader field of biology at North Carolina State University. A very warm welcome to you, Tina. Following the presentation, we will have a Q&A session, and we welcome any questions that you may have. Please ask questions using the Q&A system to the right-hand side of the video player. And now, without further ado, I will hand over to Tina to begin her presentation.
All right. Thank you so much, George. I'm very happy to be here and have the opportunity to present this talk. So Owlstone as a company, we are focused on breath as a matrix to study biology, specifically on VOCs. So VOCs are volatile organic compounds that are derived from different metabolic processes. And they can come from various sources, such as human metabolism, microbial metabolism, as well as external sources. So what does it mean when we see exhaled breath, VOCs coming from exhaled breath? So they can actually reflect different biological processes and diseases from not just the lungs, but also elsewhere in the body, because the VOCs can be carried with the bloodstream and be exchanged in the lungs. So why are we interested in using breath as a matrix to understand biology? So there are several advantages on using breath for studies. First off, breath is completely non-invasive, so it can be pain-free. Breath is also provides an orthogonal approach to other biomarker platforms, such as serum. It is highly accessible, and it has a huge potential of translating testings to a point of care or home-based test for the future. Most of breath is also inexhaustible supply. So unlike tissues or biofluids that you worry that you don't have enough for sampling. And VOCs that are pre-concentrated in breath has a very detection limit, can go down to the parts per trillion. So it's a very sensitive tool of measurements. It is also allows for compatible high frequency sampling. So you can do a repeated sample within a short period. So it suits for longitudinal study designs. And because VOCs are derived from metabolic processes, they can reflect what is actually happening phenotypically. And as I've just mentioned, VOCs is not just for respiratory disease, but also a way of detecting disease elsewhere that is occurring in the body. So how is this relevant to using the breath biomarkers for scientists that are working in drug development? So if we use respiratory system as an example, say like cystic fibrosis, it can be often challenging to obtain samples like sputum, whereas breath becomes a very accessible way of sampling the physiological changes that are occurring. So it allows for frequent monitoring of the patients that will help to understand the early efficacies or any adverse events that are happening with the drug treated. So this also helps with developing methods to support decentralized trials in the future. So you can do like more of an at-home or local based testing. And because breath is non-invasive, it also allows for identifying novel phenotypes for certain diseases, as well as novel biomarkers. And lastly, it allows to support post-market drugs with a very patient-friendly testing. For example, if you want to indicate exacerbation, you can use breath and see what needs are in for treating, as well as a way of indicating drug efficacy to patients and their doctor. So where are we in general in the breast research area? So if you look at the graphics on the left side, it shows the breast publications in the last 40 years. You can see there is an increasing trend. So hundreds of report VOCs have been published that associated with different biological pathways. And dozens of clinical studies have reported very promising results for potential biomarkers in different disease areas. Also, with the advancement of technology, there are multiple options for both breath collection and analysis, which includes platforms like GCMS. However, currently there are only a few clinical breath tests that are being used, like FeNO for airway inflammation in asthma, or hydrogen methane breath tests in the digestive disease areas, or using radio labeling for liver function test. So why is it that with so many breath research being published, we don't have more breath biomarkers being used in clinical settings yet? So there are a lot of challenges in translating the biomarker discovery into clinical settings. And here I list several reasons why this implementation is very challenging. So a lot of these studies that have been published are done in pilot studies. So the sample size is much smaller, and there's a lack of these findings being validated in a larger cohort. And secondly, a lot of these published research only use tentative IDs without further confirmation with the standard. So it is the identity of these VOCs are not certain yet. Moreover, these VOCs that have been suggested as potential biomarkers aren't shown the concentration range that occurs on breath. And this can be an issue because there are so many different ways of collecting breath and also analyzing these VOC compounds. So how do you know if different studies can be comparable? Another thing here that is quite challenging is the suitability of any identified biomarkers throughout these studies because of the comparison using healthy patients versus disease patients. And because breath is a relatively new research field, there are many unknowns that still requires a lot of exploration. So in order to have to meet these challenges and produce high quality data, there are also several challenges in the process of obtaining these high quality data. So for example, how do we distinguish potential biologically relevant breath VOCs that also happen to occur within the environment and can be breathed into these patients? And also, how do we reduce the false positive findings through minimizing the variability that comes either from the biology or the analytical process? And finally, as I mentioned, there are so many different ways of collecting breath samples and also doing the analytical process. So how do we specify the range of compounds that can be easily comparable throughout different studies? So at Owlstone, we have been addressing some of these mentioned challenges as we focus on the clinical translation of biomarkers into clinical testings. We have developed platforms to focus on the clinical translation, especially finding suitable VOCs that either have been highlighted in literature as a promising biomarker or completely a new discovery approach. So discovery studies can be done in two ways. One is the top-down approach in human clinical trials that it's an untargeted analysis, which will incorporate a wide range of different VOCs, and promising VOCs can be indicated throughout the level of changes depending on the cohort that is being recruited. Another approach to study VOCs is a bottom-up approach, which focuses more on any specific questions that you may have. For example, you can use in vitro studies that that can utilize VOCs that changes within the biological processes in cell lines after them being activated or inhibited. And this provides a way to identify potential target engagement or efficacy biomarkers. So to go into a little bit more on the discovery approach, let's talk a little bit on the sample collection process. So Owlstone has developed a breath collection station, which includes a receiver breath sampler, a Casper portable air supply, and also a breath collection software. So the receiver breath sampler includes a disposable mouthpiece, which is where the individuals will breathe into, and then the breath is being concentrated in the sorbent tubes, which then are sent back to our breath biopsy lab for later analysis. And the Casper portable air supply filters out ambient air, which removes a lot of the background VOCs that could be contaminations, and this allows the patients to breathe in clean air without any VOCs being confounding factors. And lastly, our breath biopsies software helps to standardize a certain volume of breath being collected. So it's a very optimized process of breath sampling and allows for specific fractions that you're interested in collecting. So we also recognize that it can be quite challenging for people to start straight with human studies, and to help find some evidence before clinical studies, we also provide in vitro study analysis, which you can focus on certain target VOCs that you're interested in, and our in vitro headspace analysis also allows for sampling in cell culture, microbial culture, as well as fecal samples. And recently, we have also developed a method for sampling breath in animal models. So this is done through modifying a FlexiVent used for mouse breath collection, and it is co-developed in collaboration with Boring. So whether it is human samples, in vitro cell culture, or samples collected through the animal models, these samples can be sent back to our breath biopsy lab, and then go through the analytical process, such as GC-MS, and then these analyses will provide feature extraction and normalization, which then we can check for what molecular features are actually on breath, as opposed to blank samples. And once we know what features are actually on breath, we can then assign different tiers of identity, providing different levels of confidence using either our standards or libraries. So this whole process is called our Omni platform, which allows for a very global analysis. So putting this all together, the Omni platform actually addresses some of the challenges that I have mentioned previously in breath VOC research. So first, it enables accurate molecular identification. And this is very important because you will want to know the actual molecular ID for later validation and assessment trials. Secondly, the Omni platform can provide a wide range of VOCs to study. So if you're doing untargeted analysis for VOC discovery, if you can have a larger number of VOCs that are collected on breath, this also increases your chances of identifying a biomarker that can be potentially useful. And as I mentioned, because of the analysis that we do to ensure what is actually considered as an on-breath compound, we know for sure that any VOCs that we found are not confounded by the background samples. And lastly, our Omni platform allows to minimize the variability that we see from the technical aspect. So right now we are trying to build a library for VOCs that can be good for research interest and for later clinical translation. So what are some of the criteria that we need to allow VOC to be useful? So first, it has to be detectable in our methodology, which I have mentioned. And secondly, we need to know that these VOCs are actually on breath and not from the environment. So to ensure VOCs that are actually on breath, we have developed a standardized way of considering 3 different matrices, which VOC has to be, it has to pass at least one of the following 3 matrices to be considered as a truly on-breath compound. So the first matrix is standard deviation, where a VOC in a sample is only on breath if it is at least 3 standard deviations above the mean of the blanks of that specific VOCs. The second matrix is a pair T test, where you match an individual breath sample to its corresponding blank. And for a given VOC of interest, this VOC is only considered on breath if it is statistically significant with a twofold increase. And the third matrix is using a prediction model with a threshold of AUC at 0.8. So any VOC has to be above this threshold to be considered as a truly VOC that is on breath. So additional to the being detectable and also being on breath, these VOCs that can be truly useful will need to be associated with relevant biological process. And to do that, we have generated a VOC atlas, which is a database that contains over 200 VOCs that exist on breath now, and the list is still continuously growing. So these VOCs are not only on breath, but we also provide quantitative data for from studies, including cohorts of healthy and diseased subjects, which allows for later comparison through different types of studies. So the VOC atlas are currently also incorporated with different biological pathways and also literatures that we have found that suggest disease association with these VOCs. So an example of VOCs generating processes is fatty acid oxidation. So this is a very important energy source, and fatty acids can be broken down through either the complete oxidation or incomplete oxidation approach. And we are able to see VOCs products from both either from both incomplete oxidation as well as complete oxidation. So the VOCs here that are highlighted in orange are found in our ALICE database. Here's another example of VOC generating processes, which is a lipid peroxidation. So it also starts with fatty acids, but it reacts with oxygen species and produce products like aldehyde, alkane, or alcohols. So as I've mentioned, that VOCs are not only just VOCs exhaled from breath are not just generated locally, but it is also systematic. So it means VOCs that are measured through exhaled breath can also be produced elsewhere, such as the microbes in our gut. So for example, short-chain fatty acids are produced through dietary fibers being fermented through the microbiome, or are the VOCs such as indole, can be produced through the microbiome by amino acids metabolism. So here, just another example of some of the biological processes that we have included in the VOC atlas. So in addition to indole, which I've mentioned in the last slide, there are several more VOCs that we know that are on breath are generated through amino acid metabolism. And we have data showing there is correlation of these breath VOCs with the gut microbiome. So as I've mentioned, several of these points that is in need to build a VOC library, we are also interested in having VOCs that are already being shown previously in other clinical studies. So from here, I'm going to transit into a few case studies, starting with a disease that has biomarkers that have been well established in literature. And we use Omni as a way of demonstrating the capacity that we can measure these compounds using our platform. So the disease here is type 2 diabetes, which is a very complex metabolic disorder and can be progressed from pre-diabetics. So diabetes requires continuous therapy with drugs and blood glucose monitoring to ensure and control to prevent the disease, to prevent development of associated comorbidities. So in this studies, we recruited both healthy controls, pre-diabetic and type 2 diabetic cohorts with well-balanced age and gender. We identified within the group of people that we studied, we later focused on a subset of patients that have fasted for over 8 hours to ensure that the VOCs that we detected are truly reflecting disease-associated metabolic changes. So in this study, we identified 156 VOCs that are statistically significant when we compare type 2 diabetes with healthy controls. And the prediction model suggests that these significant VOCs are capable to distinguish medication-treated type 2 diabetic cohorts from pre-diabetic and healthy control subjects. So some of the VOCs that we see increase in type 2 diabetes subjects are linked to the gut microbiome. So for example, acetic acid, isovaleric acid, and 3-methylindole. While 3-methylindole in this study did not reach statistical significance, but we do see a very clear trend in these populations. And we believe that with the increase of sample size, this VOC may become statistically significant. We also found increased levels of methylpropanol ketone in type 2 diabetic cohorts, which is a VOC that is associated with different diseases like NAFLD and UC, which can suggest there is disruption in the metabolic process or gut inflammation. So these VOCs or VOCs within the same pathway have all been shown to increase either in breath or blood samples of diabetes subjects in previous studies. Additionally, we also found VOCs, several VOCs that have increased in type 2 diabetes, although the biological relevance is still unknown yet. But overall, seeing these VOCs that reach statistical significance and with the interesting biological association, it indicates that our Omni platform is capable to detect disease-associated metabolites that have been established in literature, in addition to new potential breath biomarkers. So right now, I like to present a good example of how you can design a mechanistic study to develop some of the understanding in plausible origins of a biomarker. And here I use COPD as an example. So this is a disease that is characterized by lung tissue damage and reduced lung function that is resulting from tobacco smoke or air pollutions. So the eosinophils are activated by stimuli like interleukins, and this can release tissue damaging proteins or oxygen free radicals. And together they can orchestrate a bronchial inflammation, which can cause severe damage in the lung epithelium. So in this study, the focus is on biological treatment, which is aimed at reducing lung inflammation in the COPD patients. So the primary goal is to identify biomarkers that are associated with response to treatment, as well as stratifying the responders. And the second goal is to understand what associations occurs within these inflammation biomarkers. So in this study, we identified a VOC compound, which is classified as an alcohol, and it correlates significantly with blood eosinophils at the pre-treatment baseline, and also tracks the blood eosinophil changes over time. And interestingly, in a separate study done in vitro, the activation of eosinophils using PMA actually produces the same compound, which gains the confidence of the findings in the study. In addition, using prediction model to predict eosinophil counts also show that the fitted values from this compound that came from the subject throughout their different visits actually can closely are close to the line of agreement when plotted against the observed eosinophil counts. So although individual changes to blood eosinophils were relatively small, we do see there is correlation of this alcohol compound with blood eosinophils across longitudinal as well as cross-sectional. So the study demonstrates on how our platform can help develop some understanding of plausible origins of a biomarker. So as I've mentioned several times throughout this presentation, exhale breath can actually come from metabolisms of microbials in our gut. So now I'm going to give an example of how we can apply breath analysis to the gut microbiome. So using this example of a high sensitivity breath test for gut-produced ethanol in NASH, we know that ethanol overproduction by certain gut bacteria has been reported in different metabolic diseases like NAFLD and NASH, independent of alcohol intake. And this is very important because the level of ethanol that is intake is actually a part of the diagnostic protocol for NASH. And it represents an exclusion criteria for clinical trials. The high amounts of gut ethanol that is produced can ablate the beneficial effects of experimental drugs, and variability of the ethanol being produced can be an unaccounted confounder. So right now, the clinical trials ongoing that are tested for NASH drugs are aimed to correct the metabolic processes that can be exacerbated by chronic ethanol exposure. And because of this reason, ethanol intake is very strictly controlled. However, gut-produced ethanol affecting the liver has not been taken into account yet. So there is a need for a diagnostic test for gut ethanol production, and this can help to assess the control for this confounder through potentially identifying patients that are more likely to respond to therapy in clinical trials. And this will help increase the potential to bring new NASH drugs to the market. So at Owlstone, we have done a study to identify VOCs that are associated with gut dysbiosis. We're interested in looking at several VOCs which have known to be associated not just with NASH, but also disease that can, in the disease population that also have a higher risk of developing cardiovascular disease. So the study design, we recruited 10 healthy subjects, and they were fasted overnight with no alcohol drinks intake before the day of sampling. So on the day of sampling, a breath sample was collected before and after being administered with 75 grams of glucose. And several breath samples were taken within the 90 minutes after being administered with glucose. From the study, we found that gut microbial fermentation products like ethanol, acetone, which is an intermediate of the 2,3-butanediol product, as well as propionic acid, all showed a spike on breath after being administered with glucose. In addition, we also found gut microbial products that are associated with the disease but not relevant to glucose ingestion, such as trimethyl, TMA, methanol, and methane are also detected in our study. So this suggests that we are capable to measure different gut microbial produced metabolites in the breath. And this can be in the future a non-invasive method that can replace current blood collection, which allows the scaling of a larger cohort population. So as I've mentioned several examples of biomarker discovery, now I'd like to transit into how we can utilize these discovery into translation of into a clinical settings. So breath test has been widely used in digestive disease areas to help investigate some of the cause of different digestive problems, which all share a common source of discomfort, persistent discomfort. So this test is based on observation that when intestinal microbes encounter undigestible dietary substrate, it can ferment the substrate and produce different volatile gases. So in hydrogen methane breath test, an individual will ingest exogenous VOC, which is also a EVOC probe. And throughout the fermentation process by the microbiome, it can produce hydrogen and methane. And depending on the concentrations or the changes of these volatile gases, it can help determine what is the underlying causes of these gastrointestinal issues. So currently, hydrogen and methane breath test is a service that we offer by Owlstone in the UK through a referral from a healthcare practitioner. So the HMBT test is done differently than the breath biopsy collection station. So subjects will do a breath test within offsite within the at home, and they first take a baseline sample, then they ingest the substrate, and then throughout a time frame, they will provide several. They will collect several breath tests, and all of these samples are then sent back to the breath biopsy lab for later analysis. And finally, the test results will be interpreted by a clinical scientist, and the report will be sent to the patient and their doctor. So in addition to hydrogen and methane, we also found another gut bacteria produced compound that has the potential for future clinical studies. So this compound is hydrogen sulfide, which is produced by certain bacteria like sulfate-reducing bacteria. This compound acts as a gut health regulator. So depending on the concentration, it can either promote or inhibit inflammation. We know that changes of the sulfate-reducing bacteria or alterations in the levels of hydrogen sulfide are linked to gastrointestinal disorders. And within healthy individuals, the observed concentration of hydrogen sulfide is below 1.2 ppm. So levels above this have been shown to be clinically significant and correlate with diarrhea and abdominal pain. So we've done an assessment in-house on the hydrogen sulfide levels in healthy subjects, which is done similarly to the hydrogen methane testing. So a subject will ingest a substrate, and breath sample is given before the ingestion as a baseline, and afterwards throughout several time point collections. And an interesting result is that we found, although hydrogen and methane levels actually increase over the time course of the study, hydrogen sulfide actually decreases throughout the time course throughout breath test. And we know that from the study, we found that hydrogen sulfide levels are consistently below 50 ppb, which having this information helps us to establish the normal range that can be used in future clinical studies. So given the home testing of HMBD currently, we see a very high success rate above 95% with at-home testing, and the patient error rate is very, very small. It's only at 0.1. So this suggests that these at-home based testing are very safe, convenient, and easy to perform, and this can reduce the need for a patient to clinical visits, and it can also lower the demand on healthcare personnel. So we can see that in the future, breath analysis handheld device can help support decentralized clinical trials, and Owlstone is actually launching our OMED breath analyzer by the end of this year, which is a device that is connected to phone app and allows for immediate results review, as well as food record and symptoms recording. And these data will be sent to a clinician for review and later suggestions on personalized treatment plan. So as I come to the end of the presentation, we have covered the potential of breath analysis as a non-invasive diagnostic tool, the challenges that we're facing in breath research, and walked you through the process of VOC biomarker discovery in both clinical and preclinical settings. And we also talked about the validation and translation of VOCs into clinical settings, as well as the potential of future decentralized breath analysis through at-home collection. I just wanted to mention that our annual breath biopsy conference is coming up in the end of next month. And this is an online event, which is free for registration. And I'll also be presenting a poster on the diabetes studies that I've mentioned in this presentation. So thank you very much for your attention, and I hope that this presentation has been helpful for providing some information and gaining interest in using breath as a research tool to help with your research interest as well as drug development.
Thank you so much, Tina, for sharing your valuable insights on breath biomarkers. Your expertise has really provided us with a deeper understanding of this fascinating field. We are now moving on to the Q&A section of this session, and I want to take a quick moment to remind the viewers to submit any questions they may have for Tina using the chat system to the right. And without further ado, let's dive into your first question. Do you see an overlapping set of candidate biomarkers come up as top hits for distinct age-related conditions?
Sorry, can you repeat that, the question? The age-related conditions?
Yes. Do you see
Yeah, so definitely, because VOCs are reflective of the metabolic processes, so there should definitely be a difference in terms of VOC profiles within the different age groups. So we suggest that any studies that you're designing with the disease group and the healthy controls group, you would want to have age being matched more closely to remove this potential confounder in the studies.
That's an excellent answer. Thank you so much. I'm going to move on to your next question now, which is, do you think the biomarkers you have identified have potential utility in clinical practice?
Yes, I do believe that there are a lot of potentials, but I would like I mentioned in the presentation that a lot of these VOCs that are being identified will require further validation in a larger cohort, as well as a confirmed ID with standards.
Thank you so much, Tina. We have time for one final question today, which is going to be, what steps do you think would be most appropriate to take to further validate the potential mechanistic role of your candidate proteins?
Okay, so if we're talking about mechanism, then I would suggest using in vitro studies to, if you already know, let me rephrase that. So for mechanistic studies, you definitely want to use in vitro analysis rather than breath sampling, because it narrows down the scope and focuses on the specific questions. So using inhibitors, and if you know the substrate and the product, then you can use the product as a readout to see how the levels of those VOCs are changing accordingly to determine the process of the mechanism.
Thank you so much, Tina. That is an excellent answer. And unfortunately, that is all that we have time for today. Any questions that we didn't have time to get to will be sent to the speaker after the event. As with all the other talks in the event, this talk will now be available to view whenever you want for the next 30 days. And that just leaves me to say thank you once again, Tina. It's been an absolute pleasure having you present the final talk of day one of the Advances in Proteomics and Metabolomics. And for everyone watching, we'll be back tomorrow at 8 a.m. Pacific for another fantastic lineup of talks. Goodbye.
Thank you so much.